Welcome, everyone. Happy New Year, and thank you for joining us today as part of our IB User Group webinar series. My name is Mike Schmeinen with Imaging Biometrics, and today's webinar is titled Utilizing Quantitative Susceptibility Mapping for Deep Brain Stimulation. It's our pleasure to be joined today by Dr. Brian Kopell, Professor of Neurosurgery and Co-Director of the Center for Neuromodulation at the Mount Sinai Health System. Dr. Kopell is a nationally recognized leader in functional neurosurgery with extensive expertise in deep brain stimulation for movement disorders. You are welcome to submit questions using the Q&A feature, and we will unmute the microphones following the presentation so you can ask verbally as well. This webinar is being recorded and will be made available for future viewing. And with that, I am pleased to turn it over to Dr. Kopell.
Thanks very much. Thanks for inviting me here today. As described, I'm going to talk about our use case of how we utilize QSM in our workflow in our DBS practice. About 14 years ago, when I first got to Sinai, I was still utilizing T2 weighted imaging for most of my basal ganglia cases. And, those of you who maybe are still using it, I spent a lot of time tweaking these sequences to try to get the best kind of contrast at the level of the subthalamus and brainstem and basal ganglia. And it was just tedious and hit or miss. And finally, the head of neuroradiology at that time, Larry Tannenbaum, kind of took me into his office and was like, "Why are you still playing around with T2 weighted imaging? It's archaic." And he introduced me to Wang at Cornell, who introduced me to the QSM sequence. And it's been an incredibly fruitful relationship since, and it's really in very many ways revolutionized and my practice. Again, I'm not sure who is on this call, so if I go too much into certain basic stuff, I apologize. But DBS, like real estate, is about location, and ultimately our outcomes are determined by being both precise, consistent from patient to patient. And so historically, these gray matter targets that are the targets of movement disorder surgery were beyond our imaging capacity. And so what we did was atlas-based targeting with sometimes ventriculography and then later CT scan. And then even as T1 and T2 imaging entered into the fray, we really still couldn't see these images well. And so we were firmly in the era of indirect targeting. Those of us that have been through that era knows that atlases are very, very inconsistent entities. They're useful on some level, but they are bad from an individualistic standpoint. And there is a tremendous degree of individual variability of these structures, despite having relatively preserved ratios relation to AC and PC. And so our solution in those years, for many of us, for indirect targeting was microelectrode recording, the ability to record single neuron activity. But this was time intensive, and more time equals more infection, greater cost of surgery, arguably some additional risk, although it's non-linear necessarily with how many passes you do. It did give exquisite spatial resolution, but again, it mandated an awake patient. And over the almost 25 years of doing surgery, an awake patient ultimately is a more anxious patient, and awake surgery is a significant barrier to patient acceptance of a therapy that can really improve people's lives. One of the things that microelectrode recording was good for was removing the slop in the system. While head frames have a theoretical millimetric accuracy, the error can, in many ways, in real time and in real applications, exceed several millimeters. Obviously, the first example, an unbiased and not precise, is an inaccurate system. That's not what a head frame is. But head frames tend to be precise but biased, either due to handling of the frame or the other equipment that we attach to the frame, like microelectrode drives, which are not designed for the head frames. And so there's a certain bias, and that bias is a slop and in the system, and we needed a way, because we couldn't see the targets directly, we used microelectrode recording. And, it was an iterative process. It took a while. We would have to infer distances between exiting one structure and entering another to form a sort of pseudo map of our region before we made a full deployment of the electrode. Okay, but it has evolved, and we have gone from 1.5 Tesla imaging, where you really are not seeing very much, to 3 Tesla imaging, and now to our discussion today about the use of quantitative susceptibility mapping. If you can see it, you can hit it. And at the end of the day, surgery is pretty simple. If you can see your target, you can hit it. And that's the basis of surgical targeting. Quantitative susceptibility mapping essentially takes advantage of the unique iron metabolism of the basal ganglia, dopaminergic metabolism, among other neurotransmitters. You use iron as a cofactor. It is like a natural built-in contrast agent for the basal ganglia, and it really resolves basal ganglia structures in an extremely exquisite way. And you could just see an example of this patient scanned with QSM and T2, and you can see how it's not subtle, the contrast differences between the two sequences. I think the T2 weighted image on the left is a pretty pristine version of a 3 Tesla image, and you could arguably do surgery with it, but I think most people looking at QSM side by side with this would rather use QSM. And so I made the transition from indirect to direct targeting. And, when you're a surgeon, you get used to doing something a certain way. There's this energy of activation that sort of prevails to change and evolve, but you're either evolving or you're dying, and that's my philosophy. And so what we did was we looked at a number of patients, looking at concordance of microelectrode recording, best targeting versus T2 versus QSM. And once I got essentially comfortable with this, I had a much more confidence in really moving forward with QSM direct targeting. In this particular study, we looked at what was optimal microelectrode recording thickness, which was sort of traditionally for STN somewhere around 4 to 5 millimeters of thickness of STN along a trajectory of MER. And what we found in the study was that in all cases of suboptimal MER, and this was done through intraoperative CT scan, the tip of the microelectrode was not in an ideal location. It was greater than 1 millimeters from the target. That's the stereotactic slop. Adjusting for the stereotactic error resulted in a 100% MER concordance, and the mean radial error for DBS lead placement was about 0.5 millimeters. So that gave me really the confidence to truly transition over to a QSM only sequence with intraoperative imaging. I like to use intraoperative CT scan. I've done a number of MRI cases. Look, I think, a tool is a tool. I personally never liked working in the MRI suite. I found it to be cumbersome. It took longer. It didn't really necessarily help me in any way. As far as shift is concerned, shift for STN and thalamus cases, I think, are minimal to non-existent and from a clinically standpoint. GPI can be a little tricky sometimes with shift, but really most of the time not. For some other cases that I've been doing with subcallosal cingulate, where it's right near the pole of the brain, yeah, shift can be a little tricky, but that's beside the point. In our center, one of the things that makes QSM really nice is that there's automated on-scanner post-processing. I think it's seamless. So you scan the patient, the scanner does the post-processing, and it gets sent to your DICOM server. Now that's a GE system. I'm not sure if I know that Siemens has a QSM sort of automated system, maybe, but I'm used to a GE system. This is a GE native entity. It's also really important to include skull anatomy, in my opinion, especially if you're going to do intraoperative imaging with CAT scan as being your reference for best QA of image guidance. If you're going to rely on fusion, at the end of the day, having that skull anatomy is the best way to do that. We typically we do not do the CT scan with the head frame on the day of the surgery. So what I generally do, this is a slightly older slide. What I typically do is I'll get a volumetric CT along with the MRI about 2 weeks prior to surgery. In my practice, and maybe this may come as a surprise to some, I put all patients under general anesthesia and pharmacological paralysis. I like exquisitely good images, and essentially a non-moving patient gives the best kind of imaging. Pharmacological paralysis is pretty good in terms of keeping a patient from moving. And so that CT scan kind of serves as the reference scan during the fusion with the pre-op MRI. And again, the QSM skull anatomy helps make sure that you get a good fusion. I use a system where I still use a microelectrode as like a targeting tool. If you just drive an electrode, a DBS electrode home, you're really committed to at least 1.5 to 2 millimeter adjustment if you're not happy with the trajectory. A microelectrode placement prior to deploying the electrode gives you a finer ability to make adjustments, so drastic as like 1.5 to 2. We also still do a lot of research in my operating room that requires microelectrode recording, among other things. But this intraoperative CT approach, I think, allows for a blended anatomical and physiological approach that is nice and flexible. With regards to the STN use case, an example of STN on QSM is seen here. You can see I outlined the STN itself, both in the axial and the coronal plane. It's extremely easy to see this entity on QSM. There are nice little features that are more specific about STN in terms of its signal characteristics that I'll get into in a moment, but it's just a really great sequence for STN. And if you compare this to like either T2 weighted imaging or even F-Gator, which is good for some white matter stuff, QSM is the clear choice, no pun intended, in terms of visualizing the STN. In terms of the GPI use case, both F-Gator and QSM resolve the GPI quite nicely. There are aspects of white matter resolution that the F-Gator, I think, does a little bit better, especially with the optic tract and some of the internal lamina of the GPI, as well as the GPE. And what I like to do for this is get both sequences and merge them about 50-50%. And those are the two slices below. And I think that they really go together. It's like a peanut butter cup. It's like peanut butter and chocolate, great together. F-Gator and QSM is like a really nice hybrid sequence for the GPI use case. The thalamus is still like a little bit of a challenge in terms of confidently visualizing the subnuclei. Some of it is better resolved now in terms of CMPF and VIM, et cetera, but still a little bit of a challenge. QSM and F-Gator both, I think, resolve the ventral motor tier of the thalamus well. I think they're fundamentally equivalent. You could see examples of this here that they both can see VIM and VC. They are typically dark bands that are one behind the other along with a transition zone. It's pretty clear to see this at the level of the ACPC plane. Again, probably more or less equivalent there in terms of how you use QSM. I mentioned before about some specific aspects of QSM in terms of what it resolves, especially in the subthalamic nucleus. If you look over on the right, there is a consistent gradient that you see both in the axial and in the coronal planes of STN. More medially and anteriorly, it's more hyperintense and somewhat wispier in the lateral and dorsolateral portions. You can see there. I'll go into this in a minute. But from a more gross standpoint, you can see fiber tracks with the QSM itself. And so QSM bridges the connectomic and anatomical targeting information. And you can see, can people see this pointing here as I play with this?
Yes, we can.
Great, terrific. So you can see that in this axial plane, you can see the ansa lenticularis as it curves around the internal capsule. And you can also see both the striatopalatal fibers as well as the lenticular fasciculus on these fibers. And it's a really great way of kind of picking exactly where you want your electrode to trajectory in terms of getting and interacting with these fibers, which are known to result in the best motoric outcomes for Parkinson's disease. Sort of an anecdotal statement, there was one patient that had a very long STN. ANSA was quite a bit of a distance from these fibers over here. And typically when you place an electrode here with the VTA of about 3 milliamps, you're able to get into all of these particular fibers. This one patient essentially was not able to get into that because of the shape of this and had a lot of stimulation-induced dyskinesias. And when we moved the electrode a little bit more anteriorly to get into that ANSA, we were able to resolve that. So it's just an anecdotal example of that. But the fact that QSM can resolve this sort of connectomic information without traditional tractographic targeting is pretty impressive. This is the wispy versus the dense area. Outlined on the left versus the right, coronally and axially. And, when we looked at this, and obviously, we know sort of historically that the dorsolateral portion of STN was sort of the sweet spot for motoric stimulation for movement disorders. But the question does that sort of correlate with connectomic information? And so we ran a number of studies placing VTAs within and ROIs representing VTAs within the STN, both in that dense region and less dense region. And it definitely, we demonstrated a correlation that went from prefrontal to premotor to motor areas within the STN. So again, the fact that QSM bridges that connectomic and anatomical targeting information is, in my opinion, very useful and impressive. With regards to the QSM in the use case, we typically use QSM to define the ROI for our seeds to generate tracks, and then the DRTT is really have become our sole way of targeting this nucleus for tremor, both in focused ultrasound use case as well as deep brain stimulation. Now, QSM, I think, is going to emerge as more useful than just targeting. As I said, it takes advantage of the unique iron metabolism of the basal ganglia. And there's deep diagnostic information that is hidden in this type of data set. And so there is an emerging use of a image guided analysis technique called radiomics. It's a quantitative imaging approach that converts these large sets of these images into large set defined features and essentially characterizes tissue phenotype, and it can link imaging patterns to underlying biology, both prognosis and treatment response. And so we ran a study looking at the correlation of this radiomics approach in terms of correlation with on-off UPDRS3 tests. And some of our initial findings indicated that QSM may provide a better solution, or maybe an equivalent solution, but better in terms of the labor intensivity of the on-off test for patient selection for DBS for Parkinson's disease. And so ultimately, I think QSM is an integral part of multimodal imaging. There's no one single best sequence, but it's certainly a part of a multimodal imaging strategy that I think yields the best results and yields the most consistent results, which is what we want as surgeons. And, it certainly improves the ease and confidence and visualization of the basal ganglia, DBS targets, and focus ultrasound targets. Okay, I am happy to take any sort of questions at this time. Let's see here. I will stop sharing. Thanks.
Thank you so much. That was excellent. We are ready to field some questions. If people want to use the chat or QA, or even the, you can also submit, just raise your hand and we'll pick it up, and you can ask verbally as well. We'll unmute your microphone. But just one thing that came to my mind was, over the years, we've been working very hard with DSC MRI to standardize the acquisition and post-processing of that data. So what are the current challenges, if any, in standardizing QSM acquisition and reconstruction across scanners and institutions?
Well, the only thing that, and again, that's a bit of a more technical, that's sort of on the physics side, but at the end of the day, as I understand it, this tends to be a more natively GE type of scan. And so just having a GE scanner makes things easier, because then there is a pathway where, as I said, the post-processing literally exists at the scanner level. There is a sort of post-processing computer that's there, and it sort of exists on the system, and so it's seamless, Michael. You know what I'm saying? So
thank you. So the reproducibility between scanners is there, do you believe? Is it strong there?
I mean, there's a little bit, there's a little, if we go from one magnet to another, there's a little bit of tweaking that occurs that that I think is necessary. It's, and sometimes there's aspects of contrast and which echo that you want to pick up the contrast and create the quantitative map. And that has a little bit to do with what your tastes are as a surgeon, so I think that there's an opportunity to kind of tweak it that way. And I, have pretty regular discussions with our team in order to give feedback about what I'm seeing in terms of that, especially being able to see that wispy part and that non-wispy part. That's an important sort of tweak that can happen, but it's not difficult.
Okay.
Mm-hmm.
I don't see any other questions coming in at the moment.
Okay.
What do you believe are the current barriers to integrating QSM into routine preoperative imaging protocols?
First of all, I don't think a lot of people know about it, believe it or not. And so I think just people, once people see it, I think people tend to want to have it, especially if they are using sort of more traditional T2 based imaging.
Sure. Okay. All right. Well, hopefully webinars like this will help heighten awareness and make it more of a standard routine practice. So we appreciate your time. Thank you for everyone who joined today's webinar. And we'll be announcing our next session soon, which will highlight the latest and greatest features to our handheld device, IB Nimble. So stay tuned for further information on that. And again, Happy New Year and have a great day. Thank you.
Thanks, everyone. Bye-bye.